Izin untuk membuka sesi. I will try to open the session. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon from Indonesia. Good morning for Essen, Germany. Welcome to Prostate Cancer Scientific Discussion, PCAS 2023 from Indonesia. This is continuous medical education session from PT Johnson & Johnson Indonesia, collaborated with Ikatan Ahli Urologi Indonesia or Indonesian Urological Association on 10th June 2023. Before we start the session, thank you so much for your attendance, and I would like to read the disclaimer for webinar today. My name is Linggarati Ayu, and I will try to open the session with tell you about the session disclaimer. This webinar will be recorded, and by providing your and professional knowledge information, you are requesting to register in our webinar, for which the information will be used to manage your participation and to fulfill any other request you select. The information will be used by Johnson & Johnson also, our affiliates, and our service providers involved in this webinar. We go first the use of the webinar and the information you provided. By providing this information and continue to participate in this webinar, you indicate that you read, understand, and agree to these terms. This session is sponsored by Johnson & Johnson Indonesia too, and this session is only intended for healthcare professional only, whereas the objectives are to sharing and discuss the ideas, your experience, in order to increase your awareness and provide recent update and knowledge of advanced prostate cancer management strategies. This presentation does not intend to promote or influence any product and purely intended as a scientific exchange knowledge only. And if the session may contain information on products or indication currently under investigation and or that have not been approved by our regulatory authority, please refer to our product information in Indonesia. A little bit about our housekeeping today. Please kindly mute your line after this session. The Q&A session, you may open your line to speak or give your experience or advice. Then, if you have any thoughts or questions, you may put on your chat box. And also, after the session, please kindly share your thought on post-event survey, and we have some post-tests as a part of requirement for certificate. Please kindly put your complete name to be stated on the certificate, and also you will get the CME accreditation certificate. The last, please turn on your camera to take photos together in the end of the session. The rundown of the day, we have some topics of this webinar. First of all, we would like to invite for opening remarks and welcoming for Dr. Besut and Dr. Dian. Then this webinar will be moderated by Dr. Iwayan Yudiana, Specialist Urology Consultant. And also we have some wonderful topics today and very updated from Dr. Aaron, Prof. Boris Hadasik. Thank you so much for coming to this webinar session. Dr. Lukman and also Prof. Umbas for giving the great presentation today. The session will be closed by Q&A and summary and closing. So, first of all, we would like to invite our chairman of Indonesian Urological Association or IAUI, Dr. Besut Daryanto, Specialist Bedah, Specialist Urology Consultant. For Dr. Besut, time is yours.
Thank you, Dr. Linggar. Assalamualaikum warahmatullahi wabarakatuh. good afternoon in Indonesia, and good morning in Germany. Ladies and gentlemen, thank you for joining with us for this meeting. I hope you are all in a good condition. First, I say thank you for PT Johnson and Johnson for collaboration for this meeting, especially Dr. Arlin, Dr. Linggar, and Dr. Raspita Dian and team. Also, I say thank you to all speakers from Germany, Professor from Germany, and from Indonesia, Dr. Professor Rene Umbas, Dr. Lukman, and Dr. Rantingker, and also with Dr. Yudian as a moderator. Also, I thank you to all participants for this meeting. I hope this meeting can improve for the Indonesian Urology Association, and also I hope this collaboration with the especially with prostate cancer can regulatory meeting. Thank you for this kind attention. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen.
Thank you so much for opening remarks from Dr. Besut. Then we will continue for opening remarks from our Head of Medical Affairs, PT Johnson & Johnson Indonesia, to Dr. Rospita Dian. Time is yours.
Thank you, Dr. Linggar. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, and sejahtera ya bagi kita semua. Good afternoon, everyone, and good morning, Prof. Boris. First of all, I would like to express my gratitude to the God Almighty because all of us are in healthy conditions, and we have opportunity together virtually here to attend this afternoon sessions. And I would like to express my appreciations to Dr. Besut and all of the committee from the IAUI, Indonesian Urology Associations, for continued partnership so far. And we already had multiple scientific events in the last several years. And I do hope that our partnership will continue in the future. I also would like to express my appreciations to all speakers and moderator in this afternoon sessions, Prof. Raini Umbas, Dr. Lukman Hakim, Dr. Arun Tigor, Dr. Yudiana, and last but not least, our guest speaker, Prof. Boris from Germany. Thank you for your support in preparing all the materials to be delivered in this afternoon sessions. And I also would like to express my appreciations to all of the esteemed doctors who are willing to participate and learn together in these afternoon sessions. I wish that these events will run well, and all of us will get. This event will be beneficial for all of us, and at the end of the day, it also can contribute to the quality improvement of prostate cancer patients in Indonesia. I think that's all from my end. Again, thank you, and I hope this event will run well. Good afternoon, everyone. Back to you, Dr. Linggar.
Thank you. Okay, thank you so much, Dr. Dian. So we have our webinar session today with Dr. Iwayan Yudiana, Specialist Urology Consultant. Will be continued to our great speakers, Dr. Arun Tigor Sihombing, Specialist Urology Consultant, Professor Dr. Matt Boris Hadasik, Dr. Lukman Hakim, Specialist Urology Mars PhD Consultant, and also Professor Dr. Raini Umbas, Specialist Urology Consultant PhD. For open this session, I would pass to Dr. Iwayan Yudiana. Dr. Iwayan Yudiana is a medical staff at Urology Division, Medical Faculty, Udayana University, RSUP Prof. Dr. IJNJ Ngurah Denpasar, and he graduated from Medical Faculty Udayana University as medical doctor and urologist from Department of Urology, Medical Faculty Erlangga University, Surabaya. Dr. Iwayan Yudiana also published many publications in neurology disease landscape, both in local and international journals. So, Dr. Wayan Yudiana, time is yours. Thank you.
Okay, thank you, Dr. Linggar, and also Johnson and Johnson and Indonesian Urologic Association who have support this event, prostate cancer scientific discussion, first session in 2023. Okay, on this event, we will discussion about the current management of prostate cancer in MHSPC stage, especially combination systemic treatment for the optimized outcome, patient outcome, and patient survival. In this event, we have national and international experts as a speaker to give us the lecture about this topic. To shorten the time, we immediately invite the first speaker, Dr. Aaron Tigor Sihombing, PhD, to talk about the urology today, doublet and triplet treatment encountering the metaphors of MHSPC treatment. Dr. Aaron Tigor, as a lecturer and education coordinator in urologic department, Hasan Sadikin General Hospital Bandung, research manager of Medical Education Development and Innovation Center of Pajajaran University, head of academic club genitourinary system in Pajajaran University Bandung, and of course engaged in numerous presentation in national and international level as a speaker, and numerous scientific publication, and also reviewer in national and international journal. So, Dr. Aaron Tigor, time is yours.
Thank you, Dr. Wayan, for the introduction. And also thank you from Johnson and Johnson, this event. Also to Dr. Dian, Dr. Linggar, and Dr. Arlin. Long time no see. Thank you very much. So I'll be talking today about the double and triplet therapy. We know that the prostate cancer, the evolution of treatment of prostate cancer is very, very fast, I guess. And this is also because of our knowledge about cancer is also improved. But first, I want to see about the what is the incidence and the global status, and I will focus about Asia. This is the prostate cancer incidence and mortality. The ACIR is age standardized incidence rates, because we know there's a difference in age group between the Oceanian, Northern, and African. But if we see this, the incidence rate, the age standardized incidence rate is higher in the Oceania, Northern America, and also in Europe. However, if we look at the mortality rate is the highest mortality is seen in Africa and Latin America, and the third is Europe. However, if we see in Asia, Asia is very low. Even the incidence and the mortality rate is low. This is probably due because of the Human Development Index. You can see from the higher Human Development Index, the lower mortality rate. The incidence also increases. But some of the countries with high development index have a lower incidence. But improved survival actually 100% progress if we can reduce the burden of disease. It's fewer people being diagnosed or dying. That's the what we aim. And if we look in the world, the green one is when we have a top cancer per country, state. But in Asia, is most of the country in Asia is not So I think this is not surprising because we know there's heterogeneity. But how about if we put the mortality incident ratio? Now you see that the Asia become the second highest compared to Africa. And our place, Southeast Asia, is also high for the mortality incidence. So this is because of tumor. We know that there is inter-patient heterogeneity between patient, and also the problem is now there is also a different in heterogeneity in inter-tumor and intra. Now, inter-patient is because of age, sex, genetic variability. That's why the Asia is probably very low nutrition, and Asia have a different nutrition, and in Asia and European, there's a different food. Yeah. And but the problem is there's a intra-patient heterogeneity. Now, this is also we see in the prostate cancer. You can see now this is the individual, but CRPC, and we can see there is a very individual difference genetic profile between. Why there is some difference? Well, because of evolution. We started from the single cell, and then we divide the labor, but the purpose of our purpose is actually for reproduction. This is shown by this algae. Smallest one is called chlamydian, and then they will become a multicellular and work as a system of algae. The outside is somatic cells. The inside is called gonidia, with the cell for reproduction, the germ cells. And the goal is to become a reproduction. Now, we always think that the goal is like stated and linear, but actually the system itself is dynamic. It's not stated. There is a goal, decision, there's a system change, and also because of this system change, there's environment change. This is the side effect. And if there is external and internal factor, one of our cells break loose the cellular and become and have their own reproduction. And we know the goal is to have the reproduction. They have the decision, change the and change the state system, and they also change the environment. Now, this is what we see in nine epithelium, so first clone and common trunk, common ancestor, and then they have a metastasis. This is, and they all work as a system. This is also we see in the prostate cancer. So non-malignant tissue have oncogenic hits. But if you see there is a color, different color, blue, orange, and yellow, and they're all different in phenotype, and they have their own decision. They change their behavior. This is becoming complicated, as we know, because the cancer itself has each type of cell cancer have sustaining protein, has all the hallmark of cancer. So this is exactly what we see in the prostate cancer. So clinically localized disease, rising PSA, metastatic non-castrated hormone-sensitive prostate cancer, or non-metastatic castrate-resistant, becoming metastasis, and so on. So the prostate cancer from the rising PSA and become metastasis have a different clone from the cell. And imagine there is thousands of clones. So this is what we usually use. We give the metastasis, give APT, And then if there is the MCRPC, we have ADT or plus chemo or androgen receptors and or this person. Now, if we give ADT, we just probably kill just one clone. Now, what if we put ADT plus chemo or RP in advance, means in metastatic non-gastric hormone sensitive? Well, the logic here is actually that prostate cancer proliferate in the context of gastric serum levels, and it's still dependent upon androgen receptor signaling. So RP and other IG is actually developed to apply in this context. So we think that if we put this on the castration sensitive, the RP will have a effect that bigger than if we give it already castration resistant. We think it's going to have an increase of 5. So this is what we found, and it's true that the peak is there. You can see on the chart the stampede C, giving a combination therapy is better than on monotherapy alone. But every tumor have a different progression. You can see is the blue one is actually the prior local therapy. So it's synchronous metastasis, not de novo. Low volume is the best overall survival than the high volume. But de novo have a very worse prognosis. You can see if the recurrent low volume, we have a median overall survival is about 8 years. Recurrent high volume is 4.5 years. De novo low volume is just like the recurrent high volume, 4.5. But de novo high volume is very low. So we want to add years to this. So after the double therapy, we think, what if now we put the 3 of the treatment in the metastatic hormone sensitive? This is the PEACE-1 trial. It's divided the group in one standard of care plus abiraterone, standard of care plus radiotherapy, standard of care plus radiotherapy plus abiraterone. And the primary endpoint is progression and survival. And we can see that regardless of radiotherapy, because this trial is actually different approach. And the standard of care plus abiraterone have a higher overall survival progressive survival compared to standard of care. And this is also in the overall survival. See the overall, if standard of care plus abiraterone is better compared to only abiraterone without abiraterone, and also the standard of care plus abiraterone is, and we can see the high volume have the better outcome compared to only low. So high volume has a 5.1. The other trial using the treatment therapy is darolutamide, RS5. So the stratification extent of this and then randomized to ADT plus docetaxel 6 cycles of docetaxel plus placebo. And you can see the standard of care plus darolutamide is better than only placebo. Yeah. Survival, disease progression, and also a pain event. Now we think if we have more drugs, great about the side effect. But the side effect itself, it's actually, you can see, it's not very different at all. So all the adverse event is 99.5, and this is 98. So it's not very different. So this side effect is not increased by adding more drugs. Because we are talking about, I'm going to have a network meta-analysis. This network meta-analysis, the first network meta-analysis, not looking the low or high volume. So we are not looking for the low or high volume disease. See that triple therapy is better than ADT alone. And most of the triple therapy have a hazard ratio lower than the other. But after looking at the high and low volume, it seems that triple therapy is if you give triple therapy is better in the high volume patient. The hazard the darolutamide, docetaxel, and ADT, adverse docetaxel, but and the worst is only monotherapy alone. So monotherapy is not adequate for that cancer, metastatic cancer. But treatment, we have to think about all the factors that how can we choose. There is a cancer-related factor, clinician-related factors, treatment-related factor, and patient-related. And well, the cost is, I think, is the most in Indonesia, and we have to think about the comorbidities and also the performance status of the patient, and also the social. Now, what if not? We know that the triple therapy in high volume in chemotherapy eligible patient is better than only the double. Can we add more, or we stop cancer? Unfortunately, no, because of the evolution game theory, evolutionary game theory. Probably the tumor itself could resist the treatment. We can see the proof from the chemo-resistant evolution. This is from the breast cancer. You can see this is circle, and after the treatment, there is a different. You can see this is the triangle. So different treatment is different cancer emerges after we give a treatment. So there's a new clone every time we give an treatment. So we have to think about the genetic, phenotypic, and also probably we'll have to individualize every treatment and every person. So the consideration is the lifestyle of the patient, the comorbidity, the finance of the patient. What the cancer prognosis? Can we have a biomarker for that? Synchronous or metachronous, I mean de novo or relapse of the PSA, or the extent of metastasis, and the future direction. I think the genetic, epigenetic, molecular imaging will be helpful to decide the treatment. Now, even though we have the study is probably about 4 to 5 years, but most of the time, most of the urologists and oncologists only use ADT alone. You can see the light blue is ADT alone. The dark blue is ADT plus non-steroidal anti-androgen. The red one is ADT plus RP. The orange one is ADT plus docetaxel. And you can see from 2014 to 2014, 2019, there is not much change in urology. And I'm surprised to see that the oncologist is better than urologist when choosing the treatment. Most of the urologists in 2019 still use ADT alone. And even only small percentage using the ADT therapy and ADT plus docetaxel compared to oncologists only. But most of the time, you can see both of them still use the ADT plus NSAA, not the newer treatment. So in conclusion, cancer is a dynamic disease. Compared to double treatment, prolong overall survival and progression-free survival in high volume disease. From network meta-analysis, triple therapy best on high volume. And the problem for us is tumor heterogeneity. And this is from my hospital, and I love to see this. So we have to remember not only the treatment, because we don't add years to life, but add life. Thank you very much.
Okay, thank you very much, Dr. Aaron Tigor. Interesting lecture about the basic of tumor heterogeneity as a basis for combination systemic treatment for patients with metastatic hormone-sensitive prostate cancer, both of double or triplet therapy, and also many factors contributing to the treatment decision. Okay, we next to the second speaker. Good morning, Professor Boris Hadasik. Professor Boris, since 2017 as a director and chairman in the Department of Urology, Asian University Hospital, University of Duisburg, Asian, Germany. Professor Hadasik has won numerous awards, including the German Urologic Association Highest Scientific Award, the Maximilian Nates Prize, and he has authored more than 200 peer-reviewed articles and currently has an high index of 36. And of course, Professor Boris, membership of a medical society in Europe, and of course, American Urologic Association. Professor Boris will be talk about the double or triplet treatment in between for the metastatic hormone-sensitive prostate cancer. Professor Boris, time is yours.
Thank you. So thank you very much for the kind introduction, and just share my screen. Just a second. Okay. So it's really an honor being here and speaking to you in Indonesia. In Germany is small, Indonesia is very big. So I'm very happy to be here, and thank you, Jansen, for the support to make this possible. So I changed the title a little bit because I want to give you an update from the very recent ASCO meeting in Chicago. I returned on Wednesday, so now Saturday you get an update. Doublet, triplet, or quadruplet therapy. What should we choose? I think the first talk was really brilliant, and it is important that we, as a urology community, really have to learn that ADT alone is not enough. You know, if you are scared of chemotherapy, then don't bother too much to think about quadruplet therapy, but ADT alone is not enough. Okay, so my conflicts of interest are rather balanced. I do a lot of talks and clinical studies with various companies. So you have had a more thorough introduction, but prostate cancer, as you know, is a common cancer. In my part of the world, it's the most common solid tumor and the second most common cause of cancer morbidity. And I think this curve is really important because it depends on how frequently you use PSA that shapes how much prostate cancer you find. And in Germany, we really have good outcomes if the cancer is localized. Yeah, compared to the normal or the general population, if we find localized prostate cancer, this patient is going to do fine over the next 5 years. I mean, there are certainly people with stage 3 dying of the disease, but not within 5 years. But if we diagnose men in a metastatic setting, yeah, these men are dying. They are not dying fast, but they are dying of the disease. So we have to really encourage men taking PSA tests so that we find less men that are primary or de novo metastasized. And this is something where, for example, another of my specialties, imaging, comes into play. So men don't like the finger for early detection. I think PSA and MRI are really means that we can embrace PSA screening and reach out to the community, because at present in Germany, 1 in 4 men is diagnosed in a metastatic state, and this is not good. The most recent update of the European screening study for PSA has shown that if you have long time to observe screening populations, the numbers develop in favor. So you have a 30% reduction in prostate cancer specific mortality. And when you wait long enough, it's not thousands of men you have to invite to screening. But here in the most recent update with 20 years of follow-up, 246 men need to be invited to screening. Yeah. So 250 letters sent out. Yeah. And you have to diagnose 14 men with prostate cancer to save 1 life. I think this is a good balance. So really, prostate cancer screening, which this is not part of the official healthcare system in Germany, we are fighting for as urologists, because I think it makes sense. It really makes sense. Now, what do we do with these men that present with metastatic hormone-sensitive prostate cancer? They certainly need systemic treatment, and ADT alone is not enough. You have already learned that there is a difference whether this patient presents with synchronous, so de novo metastases, or whether this patient has had prior local treatment a few years ago. If a patient presents with high volume de novo disease, his chances of overall survival are less good than a patient with low volume metastases that occur years after radical prostatectomy, for example. So this is a consideration. Then another consideration certainly is, where are the metastases? We know that bone metastases are the most common, but if you have a patient, for example, with aggressive disease and liver metastases, his outcome is worse. So this is something we have to take into consideration. At ASCO, a Spanish study has been presented by David Olmos, that confirmed again there is a genetic background. So if you have a patient with a BRCA1/2 mutation, his prognosis again is worse. Yeah, so he will survive shorter than a patient without BRCA mutation. And so this is something where testing comes into play, and I will talk about testing at the end of my talk once more. But this was, confirmed in a group with more than 600 patients from Spain. Imaging is important, and PSMA PET. I mean, there's a tsunami all over the world. I believe that PSMA PET is also available, at least in some places in Indonesia. You certainly don't have to do it for everybody, because all clinical studies are based on conventional imaging. But I believe that within the next 10 years, PSMA PET will really help us to more clearly define patient populations, because PSMA PET is not only more sensitive, but it is more specific. So there are false positive lesions when you do conventional imaging, and this sometimes is important, and I will show you that in a second. So PSMA PET is not only more sensitive, but also more specific. And for PSMA PET as a global initiative, we just defined the PROMISE version 2 scoring system, so that all over the world, PSMA PET can be scored according to this PROMISE now version 2 criteria, so that you don't need a lot of text. You just need the PROMISE score. And the novelty of PROMISE version 2 is that we also look to the local prostate, and we take into consideration the expression score of PSMA inside the prostate and inside the whole body to be able to define early on whether this patient is a candidate for radioligand therapy, for example, in the future. So here I brought you one patient. He has a molecular imaging, so PSMA T stadium 2 with multiple quadrants of the prostate with cancer. He has one lymph node in a rather odd space here, pararectal, but that's clear. So, I mean, if you do surgery, this is something you have to know in advance, and it's a little bit challenging to go back down here. The PSMA expression is very high, so it's a primary 5. The nuclear medicine specialist says, well, this is very likely prostate cancer. And with a PSMA expression score of 3, if he develops metastasis later on, he would be a good candidate for radioligand therapy if the tumor doesn't change very much over time, because if you have learned from the first talk, there certainly is evolution, and in few cases also PSMA expression changes over time when cancers get more aggressive. It is important to know that there are various tracers available for primary staging and staging further down the road, and all these tracers behave a little bit differently. I believe globally the PSMA 11 tracer is the most available one because there is no patent protection. It was found in Heidelberg, where I did my first academic career, and I had the pleasure to be involved in many of the early PSMA studies. And this is a nice tracer, but with urinary excretion, and some of the more novel tracers like PSMA 1007, there's no signal in the bladder. So this one is a little bit more beneficial if you look for local recurrences. But this F18 tracer also sometimes gives false positive bone signals, which is important to just know. So speak to your colleagues what they are using and to find out what is important. The European guidelines clearly state that PSMA PET imaging is nice, but it's a toy at present, and we should not change clinical practice just based on PSMA PET because we have only little outcome data correlating imaging with long-term outcomes. But I want to dispute this a little bit because I mean, times are changing and we get more and more outcome data for PSMA PET. And I'm a little bit hesitant not to believe PSMA PET because it's more specific. And I show you a very recent presentation at ASCO. It was discussed in the poster discussion session from Wolfgang Fendler, who is a colleague of mine here in Essen. And here in a global effort, they looked at 10,000 patients with PSMA PET, and they looked at those men who got a standard bone scan at time of PSMA PET and at various stages. And what they found in this work that will be published shortly in the Journal of Nuclear Medicine is that if you look at basic bone scan without SPECT-CT, not taking into consideration everything, but if you have a patient with primary disease, you just do a bone scan as has been used in STAMPEDE, so without SPECT, there is a high likelihood of false positive results. And if you have a false positive bone scan, this patient is oligometastatic, but that's false. And so this explains a little bit why maybe this STAMPEDE population of men with little metastases might benefit from radiotherapy, while men with polymetastasis do not. This is purely hypothesis generating, but there is some chance of at least a few false positives in the STAMPEDE cohort. If you look at another stage, at here MHSPC, we compare charted to PSMA PET, and there are charted low volume patients with disseminated high volume PSMA PET disease. So again, there is a fraction of patients in the low volume cohort now that clearly need systemic treatment. So there is stage migration if you use better imaging. And this is a very recent publication from Münster, another place in Germany close by, where they were able to show across various stages of prostate cancer, if you have a high volume disease, so I mean 200 mils, this is really high volume, your chances of surviving prostate cancer are much lower, as for example here you have metachronous small volume recurrence after primary treatment. So PSMA PET is really correlating with outcome, and it is providing, I think, important information. So this is something that you should be aware of, and if you have access to PSMA PET, carefully use it. So at ASCO, in the discussion, it was really said that it is time to move from bone scan in prostate cancer. Nuclear medicine does not like bone scan anymore, but we certainly acknowledge that it has been used in all phase 3 clinical trials until now. And so now we have to integrate PSMA PET, and Janssen is doing this, for example, in the PROTOS study, for prostatectomy in the context of neoadjuvant and adjuvant therapy with apalutamide, and also in the Primordium study where in biochemical recurrence, we're testing the use of apalutamide. At present, we have to really build bridges between the old knowledge and the new knowledge, and we'll see. So the standard of care in MHSPC clearly has evolved, and I believe that you know all these studies, and the triple therapy studies have been presented in the first talk, so we can be quick here. Docetaxel has been shown to extend overall survival. Abiraterone is great, and now it's cheaper, so it's very useful. I really like abiraterone. Enzalutamide, apalutamide are certainly also excellent AR signaling inhibitors, and radiation therapy to the primary is something we use as standard of care for oligometastases. But we in general, we would also go for the metastases with treatment intent. So it's a little bit a change as compared to STAMPEDE, and we also have to discuss whether these men should get at least a short period of intensified therapy. I come to that in a second. Triple therapy, PIS1 and darolutamide have been presented to you, and I will give you an update on the PIS1 data because the radiotherapy part has been presented at ASCO last week. So a very recent publication with regards to enzalutamide comes from Andy Armstrong and his group, and they looked in the ARCHES trial whether there are differences between the benefit of enzalutamide as compared to low volume or high volume disease. And both low volume and high volume patients clearly benefit from intensified treatment, and there is no threshold. So even a man with one metastasis seems to benefit from intensified systemic treatment. So there is no threshold. So I think it's really important to get the message out that we should start and hit harder and earlier in hormone-sensitive disease, not with ADT alone, but with ADT plus another hormonal agent. That could be ENZA, but also APA or abiraterone. Abiraterone in Germany is not reimbursed for this purpose. We can only use abiraterone in patients with latitude high risk, but I don't know about Indonesia. I think intensified treatment really makes sense. But I come to that, I don't think that we have to give it for prolonged times. So the EAU guidelines clearly state ADT monotherapy is out. We should not use that anymore. This is important. The doublet therapy get a strong recommendation regardless of the choice of drug. And for oligometastases, there is radiotherapy because of that pre-specified subgroup analysis of STAMPEDE. Docetaxel alone as combination partner to ADT is also out. Docetaxel should only be used anymore in the context of triple therapy. But the added benefit of docetaxel to a doublet has not clearly been defined. So we don't know whether the addition of docetaxel as compared to a hormonal doublet is providing a lot of benefit. So the recommendation is strong only in that regard that if you want to give docetaxel, don't give it alone. we don't have good trials to define the additional value of docetaxel, and so we rely on meta-analyses, and the very recent one has been presented to you. Another one that I like to quote a lot, because I want to encourage urologists to really use doublet therapy. Docetaxel alone, there's no arm here ADT alone, it's docetaxel alone, is clearly inferior to a hormonal doublet or the triple therapy. But the difference here between triplet therapy and doublet therapy is small. Yeah. So if you, as a take-home message, take home that give doublet therapy to all your patients that are fit to receive treatment, then I'm very happy. There is a more granular systematic review that was published in European Urology, where you can look at here patients high volume, low volume, and high volume clearly. Here this is piece 1 data, because the paper was published before the ARASENS study showed the differences between high and low volume. So here a triple therapy is best for patients with de novo metastases. Here again, triplet therapy is best, but all patients with lower volume or metachronous disease, a doublet seems to be the winner in this systematic review. And here, this work from Frankfurt in Germany has been presented to you. For low volume, the standard of care is doublet. For high volume, the standard of care is either doublet, or here the ARASENS hazard ratios are below 1. So for high volume, I discuss triplet therapy, but I don't use it in all my patients. And why, I come to that in a second. There are various publications looking at treatment patterns, and this one is not according to specialty, but it's just showing the data from the US until 2019, was presented at ESMO last year. And you can see doublet therapy is rising, but ADT alone, again, is still used far too often. Yeah. I'm looking for updated data, and I believe that ADT alone should really drop. It is common sense, but certainly it depends on your region. So in Germany, luckily, we don't have financial toxicity. Our healthcare system does cover doublet therapy for all patients. Yeah, so there is no reason to use ADT alone unless you have a very incompliant patient or an unfit patient, where I even do surgical castration in some places. Okay. If you use a doublet therapy, I think the choice of drug is perfectly up to you. This is a real-world observation from ASCO GU from this year, looking at APA versus ABI and ENSA, and patients with APA in real world. They do nicely here. 88% were still alive after 1.5 years. Well, certainly this is early, but I brought you this slide because the data from clinical studies and real world practice is comparable. Yeah, it is. You don't have to be a super specialist to use any of these oral drugs. Your patients will do fine, and very likely as good as has been shown in the big clinical trials. So now, what about piece 1 quadruplet therapy? So piece 1 was accrued when times were changing. So there was first a few months with ADT alone, then the standard of care was ADT plus docetaxel, and then abiraterone was presented. So there were some changes, and this explains the complex design of the trial with these 4 arms. We know that the addition of chemotherapy or the addition of abiraterone to a double therapy of ADT and docetaxel is beneficial for men with de novo high volume metastases. And now there was analysis presented by Alberto Bossi looking at radiotherapy, whether the addition of radiotherapy to the standard of care being very often ADT plus docetaxel, or the addition of radiotherapy to ADT plus docetaxel plus abiraterone was of benefit. please note that the stratification has no stratification based on volume of metastases. It was not in here. And so I was a little bit disappointed because Alberto Bossi did not show results of radiotherapy for the overall population, but he focused on the low volume population, which is a little bit smaller. But even in this low volume population, when you have a patient that receives standard of care plus abiraterone, there was no survival benefit when you, on top of that, applied radiotherapy to the prostate. All these curves are very, very similar. So there was no overall survival benefit, and it was in contrast to STAMPEDE explained or discussed. It is most likely a reason because there is more intensified systemic treatment in PEACE-1. In STAMPEDE, there was ADT alone plus radiotherapy, and their radiotherapy seems to add benefit. But if you have intensified systemic treatment, there is no survival benefit by adding local radiotherapy to the prostate. However, local therapy to the prostate did reduce progression-free survival. And this progression-free survival was not only local progression, but also progression systemically. We still have to wait for the full publication, and it is something I think we have to discuss, and also discuss in the context of the possibility of doing surgery even in some of these men if they are very obstructive or suffer from recurrent bleeding in the prostate. But it's really not a must. This is just delay of progression, and it has no survival benefit. So we really have to wait for the full publication and carefully discuss with our patients whether local therapy is needed or not. I think that my take-home message of this presentation is radiotherapy is not very useful, and systemic treatment is the most important part if I see a patient with de novo metastases. So I think it's really, you have to establish a team. I'm speaking to you as a urologist, but we have a team in Essen. I have a specialized medical oncologist who is looking only for men with, or men and women, sorry, with GU cancers. Nuclear medicine and radiation oncology are really parts of the team. We have some systems biologists and IT specialists that really help us to understand patients. And one of the important parts is that has been shown again in the first presentation, I really liked very much, is we have to balance. We don't just want to add years to life. Quality of life is important. Quality of our patients is the most important. And this is why triple therapy is not my routine approach, because I know from STAMPEDE that quality of life with chemotherapy, at least for a few months, is suffering. So I have to discuss with my patients. If it's a very fit young patient who knows that he will get chemotherapy at some point of time anyhow, he might elect to go ahead with triple therapy. If it's a patient who is a little bit elderly, we might start just with a doublet and then wait for castration resistance and then discuss radioligands versus chemotherapy, because we'll see. If a patient wants chemo, he has to acknowledge that quality of life is suffering a little bit. But combining of hormones as a triple therapy, there was data from combining ABI and ENSA, plus ADT. So a triple hormonal therapy is also too much, because we add cardiac toxicity. So combining ABI and ENSA or APA and ABI is out. We don't do this anymore because it adds toxicity without a benefit. The good news is we did make progress in prostate cancer. There's some benefits of early detection, but also systemic treatment was improved. So here this brown curve is prostate mortality is really going down. The red curve is lung cancer. There was a little bit more progress, but prostate cancer, we are doing fine. And here on the right side is the number of deaths avoided, and this kind of starts, the curve start to separate with the establishment of comprehensive cancer centers, where we discuss patients and really know what to do with our patients. So to conclude my talk, there's always the discussion. I focused on imaging. I really like imaging. I think it helps us to stratify our patients. What about now germline testing and things like that? Because I mean, that affects the whole family. It is rather expensive in Germany. It's not reimbursed always. So it is really a balancing act, and it is more complicated because in Europe, we now can prescribe olaparib in combination with abiraterone to all men with MCRPC, regardless of testing. But I don't like it because, again, it adds toxicity. So I am pro-testing for men that present with de novo metastases, but for reimbursement issues, I do the BRCA testing only after they progress after one line of hormonal therapy, because then it is reimbursed in my healthcare context. If it would be reimbursed earlier, I would test earlier, because I think it is important to know if that patient has a BRCA mutation, because he is poor prognosis and because this patient group really is benefiting a lot from PARP inhibitors. PARP inhibitors were not part of my talk, but they are being tested in hormone-sensitive disease earlier on in amplitudes and in the TALAPO-3 study. And it has been shown in the studies with olaparib, niraparib, and talazoparib that men with BRCA mutations really have an enormous benefit. So the hazard ratios are somewhere around 0.2. Yeah, so I think it's important to know whether there are genetic changes. The guidelines suggest, as I told you, to consider testing in men with metastatic prostate cancer. And it's a strong recommendation for men with MCRPC. Yeah, so this is where I do it because I have reimbursement for that. And up here in hormone-sensitive disease, I discuss it, but I say we wait a little bit more because then it will be paid for. My last slide, or the second to last slide, I think the future will be more individualized therapy. So, for example, with men with BRCA mutations, I believe that PARP inhibition plays a big role earlier on. For men with high standard uptake values, so high PSMA positivity, I believe that the PSMA addition story might be positive, where we have a triple therapy of ADT plus a hormonal agent plus radioligand therapy. For patients with primary visceral disease, I think chemotherapy is still important. It is something to discuss. But the other main point I want to make is, for example, if I have a man with oligometastases, and I go also after radiation therapy for the oligometastases, I certainly stop treatment after 2 years. I want to find out what has happened. These are not men where I continue therapy forever. And also in men that have an optimal PSA response, maybe they are low volume disease, they have metachronous disease, they respond nicely. We can discuss treatment intensification, and there are studies ongoing testing whether you can leave out ADT or whether you can stop everything and just monitor the PSA value like intermittent therapy. So I think also here this de-intensification to improve quality of life is something we have to test within clinical studies. Yeah, we have to find out whether there is benefit from a quality of life aspect. The recent presentation of the EMBARK study of enzalutamide in men with biochemical recurrence was certainly interesting. I had hoped for enzalutamide monotherapy to be favorable with regards to adverse events. That was not the case. And so now I have to wait for quality of life data. So it is interesting. And I think over the next decade, we really are learning how to improve on more personalized therapy. And this is what makes urology so nice. We have longer patient survival, and we take care of the patients from diagnosis till palliative care, and we get to know our patients and discuss with them. So it is nice. So my conclusions: don't use ADT alone anymore. This is out. This is a mistake unless you have a very vulnerable or fragile patient with a very short life expectancy. Doublet is standard of care in my practice. Triplet therapy is offered to fit men with de novo high volume disease. Local therapy, as presented in PEACE, can delay symptoms and local progression. And I even discuss radical prostatectomy with very, very, very select patients sometimes. I believe biomarkers are important and promising with regards to BRCA and PSMA avidity, and our patients are living longer. So quality of life is important, and don't forget, for example, osteoprotection. If you have a patient that is on intensified therapy for 5 years, his likelihood of osteoporotic fractures is very high. So really measure bone density from time to time and see the patient in your team as a whole. Thank you so much for your attention, and I'm looking forward to the continuing talks and the discussion, and thank you.
Okay, thank you very much, Professor Boris, for the very interesting lecture about the how we diagnose and staging for the patient with prostate cancer, and then patient selection to eligibility, double or triplet treatment, especially for the high volume prostate cancer. I forget, Professor Boris, very interest and concern for the development of prostate cancer diagnostic and therapy, such as image guiding biopsy and include molecular targeting treatment. So in the future, maybe personalized medicine and individualized cancer care will be a priority to the patient outcome and quality of life. Thank you, Professor Boris. And next, we invite the third speaker, Dr. Lukman Hakim, PhD. Since 2021, he has head urology, head of clinical research unit, and member of research ethics committee at the Airlangga University Teaching Hospital in Surabaya, Indonesia. Professional position, he has both member in numerous society of urology. Dr. Lukman Hakim will be lecture about the discussion case sharing with the triple therapy in metastatic hormone sensitive prostate cancer patient. Dr. Lukman Hakim, time is yours.
Thank you, Dr. Yudhina. Can you hear my voice?
Yes,
Yeah?
Dr. Lukman,
Okay. Yeah, first of all, I would like to greet Professor Boris. Thank you very much, Professor Boris, to allocate your time and being with us today for a discussion about triplet and triplet therapy and prostate cancer. It is a great honor for us to have you as a urologist who is expert in systemic treatment. And also greetings to Professor Umbas, Dr. Aaron Tigor, Dr. Yudhina, and all our colleagues who is attending this meeting. I believe it is now already 176 participants. Hopefully they will survive until the end of the meeting today. And lastly, I would like to thank our friends from Johnson & Johnson who kindly facilitate this meeting today. You are a big support for all of us in this discussion today. Now, my talk today will be about a sharing case of one of my patients who had a triplet therapy. In between my slides, I was hoping and prepared already some questions to be answered by all participants, just to have an interactive session, and we can learn together the benefit of triplet therapy for MCSPC. Jadi nanti mohon sejawat sekalian yang hadir, kalau ada pertanyaan, cuma ada 5 bisa ikut aktif jawab sebisanya ya. Karena memang tidak ada benar, tidak ada salah, tapi kasus triplet sama duplet ini, ini memang boleh dibilang ya sudah baku, tetapi masih ada art of medicine di dalamnya. Jadi kita bisa lihat dari kasus yang akan saya. So the case was a male of 73 years old with PS2. He initially came to me in June 2022, complaining about severe LUTs and occasional hematuria, and also pain at the bony part on the back of his body. The total PSA at that time was 683 nanogram per ml, and testosterone was 303. Liver function and kidney function was normal. He only had primary hypertension as his comorbidity, but well controlled and visit his cardiologist regularly. Now let's take a look further into the history of this patient before he came to me. In February 2017, he had a PSA of about 200 nanogram per ml. We didn't remember the exact value of PSA at the time. And he underwent a prostate biopsy in my hometown, Surabaya, by a urologist with negative results. So the urologist decided to treat Zoladex and Casodex for this patient, and PSA went down to 3 nanogram per ml within 6 months time of the treatment of the ADD. At this time, no histopathological results to prove that he had adenocarcinoma of the prostate was available. And then 2.5 years later, during the treatment after the first 6 months of ADT, when he saw that PSA went down significantly to 3 nanogram per ml, he was happy. But then this happiness was continued with a non-regular follow-up to his urologist, and he didn't get regularly the ADT after the 6 months of treatment. And then by October 2020, PSA rise up to 25.11. He still didn't do the regular check-up with the urologist. And 1 month thereafter, PSA increased further to 61 nanogram per ml. By this time, it was not happiness that occurred to him, but frustration. Therefore, he decided no additional treatment. I didn't want to go to the urologist anymore, stop the ADT completely, and decided to have a herbal therapy, which I don't know what kind of herbal therapy. Now, Professor Boris, don't be too surprised that if I mention about herbal therapy, it's quite common in our country that our society expect miracle from herbal therapy. Anyway, before we continue the presentation, I would like to raise the first question to all of you. Should we need any imaging for this patient? Which kind of imaging would you plan for this patient? Now, you can, of course, choose any of the 7 options. There are no wrong or rights, but we can see, I bet that the answer will be diverse between all of us. Okay. Some more answers, please, from the participant. We only had 20% so far. Mungkin kalau ada yang belum jawab, silakan jawab. Tidak ada masalah, tidak ada masalah di sini. Supaya kita bisa tahu pilihan-pilihannya. Let's give another 10 seconds. Okay, I think we have 30% of answers. And we can see here that most of you will choose PSMA at CD, which is the gold standard. I fully agree with Professor Boris as well. And then the second choice would be contrast enhanced CT scan in combination with bone scan, which is of course not wrong. And then we have other answers such as CT alone or bone scan alone. 8% of participants who answered bone survey and 2% of FDG colon PET scan, and also 6% of full body MRI. Okay, let's continue the. Can anyone please stop sharing the answer of pooling? Okay, let's continue the presentation. Anyway, this patient had a whole body MRI of 3 Tesla. As we can see the result on the right side, the Pirates 5 was diagnosed by our dedicated radiologist with a tumor invading extracapsular of the prostate and also involving bilateral seminal vesicles. Multiple lymph node enlargement were detected with multiple bone metastases and lung metastasis. So this is the results of a whole body MRI of 3 Tesla. Now, before we continue the presentation, could you please answer the next question? In your opinion, what is the diagnosis of this patient? This is important and related to also the presentation of Dr. Aaron Tiger and Professor Boris. What is the diagnosis of this patient? Okay, now we have some answers already, still with diverse answers. Okay, 15% of answers. Let's wait for another 20 seconds probably. Ada yang lain mau menambahkan jawaban? Tidak ada yang salah, khawatir. It already stopped by 18% of participants answered. Okay, let's close this pool. Now, most of you answered synchronous metastatic castrate-sensitive cancer, high volume for this patient, which I also agree. And then some of you answered synchronous metastatic castrate-sensitive cancer, low volume. Some of you also answered metastatic prostate cancer only. And then the rest, option E, metachronous metastatic castrate-sensitive cancer of high volume. Okay, now let's continue the presentation with the next question, number 3. What would be your definitive treatment for this patient? Now, most of you already answered, agreed on one thing, that this patient is considered as having metastatic cancer, but then some diversity occur. We need to decide which type of metastatic prostate cancer is this patient having at this moment. Now, it's very quick. We have almost 25%. Yeah, most of you decided to treat this patient using the scheme of triplet therapy by giving ADT, novel hormonal agents, and therapy. Some of you decide to provide triplet therapy by giving ADT and NHA, and some others ADT chemotherapy, and 10% of you would provide ADT NHA for therapy. Okay, let's continue now. Now, I decided to give this patient triplet therapy by doing TURP first because he is suffering from the severe LUTS and occasional hematuria. Histopathological result shows adenocarcinoma of lesion 10, 5+5. So ADT was immediately given. 2 weeks thereafter, docetaxel high dose of 75 milligram per meter square with interval of 3 weeks. It's also given in combination with 2 times methylprednisolone. Now, I didn't give the abiraterone since the beginning, but abiraterone was given after the 2 cycles of chemotherapy to observe whether this patient will have a significant side effect of the first ADT plus docetaxel. Now, let us see the PSA trend of this patient. As I mentioned earlier, the first 3 years, or not the first 3 years, the first 5 years of this patient, he received occasional ADT, but then he decided to completely stop because of his frustration, and then he continued herbal treatment. We can see that after the decision of stopping ADT, the PSA increased significantly from 61 to 683. This is a time where he came to me and I provided him with a triple therapy. PSA went down significantly to 54.2 by 4 or 5 months, 4 months, I believe. In between, after 2 cycles of ADT, I provided him the abiraterone. Now let's see further by the completion of docetaxel of 8 cycles, 6 cycles, 8 cycles, PSA reached 11.6 nanogram per ml. And then I decided to continue the ADT plus abiraterone. Surprisingly, in the next 3 months, PSA increased to 39.6. Now, this is the imaging post-treatment. If you take a look at the MRI before and after the completion of chemotherapy, while abiraterone and ADT is still continued, we can see that this is just one example that the size of bone metastatic decrease also happen in some of the metastatic lesions in the lung. Based on the RECIST criteria, this is considered as partial response. At first event, now, actually, I also agree when Professor Boris explained that we need to be wise and careful in treating patients with triplet therapy and consider the adverse event that happen. But based on my experience, this is probably true for a general population, but it doesn't have to occur in every patient. So this is an example where this patient only had a mild adverse event with the triplet therapy. CTCAE grade 1 and 2 only occurs, and simply can be solved with GCSF and symptomatic drugs. This patient never had any transfusion, either PRC, thrombocyte, or anything, but only with GCSF and symptomatic drugs. Now, the summary at this point is that total PSA following triplet therapy was 11.6, testosterone less than 2.5 nanogram per deciliter. And then if we take into consideration of some of the PSA kinetic parameters, the PSA 50% was reached within 3 months' time. PSA 90% was reached within 3 months' time. But this patient never, the PSA never reached below 0.2 nanogram per ml. Now, for the fourth questions, participants, would you kindly answer the question? What would be your diagnosis at this moment? Is it still metastatic gastric-sensitive cancer, or it is already progressing to metastatic gastric-sensitive cancer? Okay, we have almost 20% participants. This is surprising. So the proportion of answer is more to metastatic castrate-resistant prostate cancer, but still quite a lot of you consider this as metastatic castrate-sensitive prostate cancer. I'm not going to answer the question, but we will discuss further and involve Professor Raini Umbas and Professor for the discussion. So it's 53%, 52% over 48%. Let's continue the slide. Now, last question for all of you. What would be your further treatment? We have quite a lot of options here, but I have considered all the guidelines and recommendations to allow you to choose which one is suitable according to your opinion. Okay, let's wait until it reaches at least 20% of answer. 3% more, 2%, 1, yeah, okay. I think this is quite okay. Most of you will choose ADT with or without abiraterone and re-challenge of docetaxel. Okay, this is the scientific evidence behind re-challenge is a retrospective study. Some of you replace ABI by changing to other novel hormonal agents. Some of you will still continue ADT plus abiraterone, and some of you will replace novel hormonal treatment with a PARP inhibitor or capacitor. Okay, we can have the discussion of this. Now, this is the recent PSA trend. So when the PSA increased from 11.6 to 39.2, the patient is having another frustration. So he decided to stop the ADT plus abiraterone that I suggested to continue. But then he decided to only continue the ADT and add herbal treatment on top of ADT. What happens? Surprisingly, the PSA decreased within 1 month time from 39.2 to 22.7. I don't know whether this is because of the herbal or the effect of ADT plus abiraterone. And then he went to another urologist in Penang who decided to provide him ADT apalutamide radiotherapy plus herbal treatment. And another, surprisingly, the PSA went down again from 22.7 to 3.4. This is the latest PSA result that he reported to me. So I'm not in, I'm no longer his urologist to suggest his treatment, but due to our good communication, he always reported to me. Final PSA results earlier this month was 3.5 and 3.4 nanogram per liter. Now there are some things, some issues that we can discuss and learn. First is about the imaging. This is a very nice meta-analysis published in 2014, which concluded that MRI was better than PET-CT and bone scan to detect metastasis. This is one thing. Another thing is a recent publication in 2021 by the group of Bertrand Tombal from Belgium, who concluded that PSA PET scan is currently the gold standard compared to whole body MRI, but it only differs to the sensitivity on detecting lymph node involvement, not in the detection of visceral or bone metastasis. Therefore, the study concluded that PSA PET scan is, of course, the gold standard. I fully agree. But when it's not available, then whole body MRI can be an alternative. Another thing is the PSA kinetic, which I believe we urologists needs to be familiar with. Some publication, this one is from the results of Titan and Spartan study, emphasizing progression to survival and metastatic survival. Another study about PSA kinetic emphasized that time to PSA 50, time to PSA 90, time to PSA nadir of 0.2 less is a predictor of radiographic progression.
Yes. Sorry.
I think Dr. Lukman.
Sorry. What was my last slide? Is it this one?
Yep.
Okay, so the time to PSA 50%, time to PSA 90% in my patient were reached within 3 months time. It's a good sign for a radiographic progression-free survival. However, my patient never reached the PSA nadir of 0.2 nanogram per ml. That is the difference. Next is, these are the summary of treatment option for MCSVC. We have triplet, we have triplet therapy. I would like to emphasize the enzymatic results that the triplet therapy is would provide advantage to only one of the 4 subset population. It will provide benefit to those patients with synchronous and high volume disease in metastatic gastric cancer, just like the patient that I provide with. Next, which one is better between duplet and triplet? I have presented this slide earlier in the earlier meeting. There is no head-to-head comparison in terms of randomized clinical trial comparing duplet and triplet, but we may consider a direct comparison using this network meta-analysis, which include 3 important things. The meta-analysis was concluded based on the Arison's phase 1 enzymatic arches and Titan studies involving more than 5,000 sample sizes. The first important message is that novel hormonal agents plus docetaxel plus ADT significantly improve overall survivals, RPFS compared to docetaxel and ADT alone, but not when compared to NHT plus ADT. And the next important thing is that NHT plus ADT also significantly improves the overall survival. This means that the addition of docetaxel to novel hormonal agents and ADT may not delay progression or prolong survival. May not means probably. Nobody knows for sure at this moment. I agree with some in this case. Now, one last thing that we need to always keep in mind is that the flare phenomenon, which may happen to bone and PSA. Flare phenomenon consists of 2 things. The first one is called as bone flare, defined as the deterioration of bone metastasis or the new detection of bone lesion as metastatic site during treatment. Now, if we treat patient with systemic treatment in metastatic disease, we would expect by several months of treatment, re-imaging will show better appearance compared to the first imaging before treatment. But sometimes when the bone flare happens, the re-imaging will show worse signs that may show further deterioration or even new site of metastasis in the bone. But this cannot be concluded as progression. So the advice of this very nice article is that in cases with suspected bone flare, please do not stop the treatment and consider to continue with a minimum of 12 weeks before further decision related to efficacy of the treatment. Still in the same article, it has been shown here, this is a summary of several studies which show the bone flare possibility of 6% to 48%, quite high for systemic treatment in metastatic disease. Another one is the PSA flare, which I believe all of you have already known. Sometimes it is not wise to to conclude about efficacy after several months of treatment, should the PSA shows an increasing value, because this can be caused by the PSA flare, particularly when we use abiraterone and insulin. So those are the important messages that I want to emphasize. I would leave the discussion back to Dr. Lydiana. Thank you, Dr.
Okay, thank you, Dr. Luqman Hakim, for the interesting cases. And as we know, that cases most common encounter in our clinic, patient with lost follow-up because he will become better after some treatment with asymptomatic, and then 1 or 2 years later he back to our clinic with higher PSA and symptomatic. And we challenging the treatment option with double or triplet systemic treatment based on our condition, like patient comorbidities, and of course financial to the patient. Okay, the last speaker we invite Professor Raini Umbas. As we know, Prof. Raini Umbas is medical staff at the Department of Urology, Cipto Mangunkusumo Hospital, Faculty of Medicine, Indonesian University, President of Indonesian Society of Uro-Oncology. And we know Professor Umbas engaged in numerous presentations as a national and international speaker, numerous scientific publication and reviewer in national and international journal. If 3 previous speaker give a lecture about the systemic treatment or novel hormonal treatment for the metastatic prostate cancer, and now Professor Umbas talk about the novel hormonal treatment for patients with localized or locally advanced prostate cancer. For the Professor Umbas, time is yours.
Okay, thank you very much, Dr. Judian. As the moderator, I will share my screen. Let's see. No, it's not here. Okay. Can I share my screen, please? Okay. Well, good morning, Professor Boris Hadashik in Germany, and good afternoon to all my colleagues here in Indonesia. And I would like to thank Johnson & Johnson Indonesia for their kind support for this webinar. As already mentioned by Mr. Dr. Yudiana, that I will talk about novel hormonal treatment prior to metastasis. So here is my disclaimer, and it means that my talk will be limited to localized prostate cancer, which is a T1, clinical T1 or T2, and locally advanced, or clinical T3, T4, or a patient with N1 disease. And according to the literature in the last 3-4 years, this is what we have. I gave an example recommendation by ESMO in 2022. You have to look at this recommendation. This is for the high risk, local advanced, neoadjuvant ADT 4 to 6 months prior to radiotherapy. Okay, and this is maybe In the next slide, we will see it is from EAU 2023. So this is the last guidelines for the same high-risk group of patients, locally prostate cancer or locally advanced. You can see quite a big difference. We are not mentioning about new adjuvant ADT, but then in this group of patients, they have a strong suggestion to give a long-term ADT plus 2 years of abiraterone, okay, for T3, T4, or Gleason score more than 8, at least, or have a PSA more than 40, means the at least two risk factors. And it will be a similar suggestion protocol for patients with N1 disease. So no neoadjuvant, but they replace with the 2 years ADT plus, long-term ADT plus 2 years abiraterone. It will be similar with the new guidelines from NCCN this year, that again, you can see here, EBRT plus ADT 2 years plus abiraterone. But the difference that in the NCCN guidelines, they don't mention how long should you give the abiraterone. They mention about the ADT for 2 years. I think we can discuss this guidelines later on. Now, I believe that the changing of the current guidelines will be based on several studies which come up to our community in the last maybe 5 years. First was the STAMPEDE study. It started in 2011. That if you look, this is a multi-arm and multi-stage study, because you can have a locally advanced or you can have a metastatic prostate cancer, and they have a multi-arms. The standard of care is ADT plus 3 years plus radiotherapy. This is for the locally advanced. And this one is standard of care plus abiraterone for 2 years. Okay. Now, this is the first enrollment. And then in 2014, they changed it to ENSA plus abiraterone. So double NS new hormonal treatment combined with the standard of care, means the ADT. This is for the patient who received the radiotherapy. And if you look at the results here, it's really significant difference in terms of mean progression-free survival. If you can look, if you just give ADT alone, combination with EBRT, then you will have a lower progression-free survival compared to the patient who receive ADT plus abiraterone or plus ENSA. However, we have to judge this combination because of the first safety factors. By adding ENSA to ABI, will we increase the toxicity? And if we look more to the results, that adding ENSA to apalutamide, to abiraterone, will increase toxicity, as I already mentioned, but has no discernible effect on the efficacy. So we have to be careful in determined to follow the result of this one of this STAMPEDE study. Next, we have another study. This is an ongoing study. We call the ATLAS study. This is a population of patients who underwent radiotherapy with 3 double-blind placebo-controlled apalutamide added to ADT and on high risk localized or locally advanced. So again, this is prior to metastasis disease. This is their protocol. that this is the inclusion criteria. Then they have two randomization. The first one is apalutamide plus placebo plus LH-RH analog. This is for 4 months treatment, 4 times 28 days. And the other group received placebo plus bicalutamide and LH-RH analog. After that, they gave radiotherapy in some point here after 2 cycles. Then they continue. In the first group, they continue with apalutamide 240 milligrams per day in combination with the LH-RH analog, while in this group, they're still receiving placebo and then RH analog. And this is the primary outcome that from this study actually to look at the metastasis-free survival. It is logic. These patients with conventional imaging, we decided, okay, there was no metastasis. Then we started to give this treatment. A secondary outcome that we would like to see how about the survival of this patient and time to have distant metastasis, because this is an important step that we need to change the treatment in this patient. So we have to wait for the results. The second one is what we call the ATLAS study, population with radiotherapy, and they gave hypofractionation. Hypofractionation means they gave 3 gray or 2.5 gray per day. That with this modality, you can shorten the time of radiotherapy treatment. Instead of 6 to 8 weeks, then here you need only 4 to 6 weeks treatment time. I think this is an important step, and I believe in some centers which have an IMRT or IGMT machines, in some of the centers, they already started to give hypofractionation with 3 gray treatment per day. And this is the one of the difference with the other study. So the conclusion of at this moment that the ATLAS enrollment is complete, but once again, as already mentioned, we have to wait for the results, for the follow-up, of course, and look how about the metastatic free survival, because that's important. We would like to delay, and of course we have to look, is there any more or less side effects or quality of life changes by using the hypofractionations. Although I think using hypofractionation by giving 3 gray per day is already common in some centers abroad. In Indonesia, we just started. And even we will have what we call the ultra hypofractionation. I will mention in another slides. Next is a Proteus study. This is a randomized, double-blind, placebo-controlled phase 3 trial, apalutamide plus ADT versus placebo plus ADT prior to and after radical prostatectomy in patients with localized or locally advanced. We know that until now, there are no guidelines mentioning about giving a neoadjuvant treatment prior to radical prostatectomy. Now, this is an interesting one. This is the protocols. So, candidate for radical prostatectomies with, of course, pelvic lymph node dissection, high risk, locally prostate or locally advanced, means T3 or T4. They give 6 months of neoadjuvant treatment, apalutamide plus ADT, and the other group receiving placebo. And then we perform the radical prostatectomy plus pelvic lymph node dissection. And after that, it will be continue with another 6 months of treatment. again, apalutamide plus placebo, comparing to placebo. So they monitor the PSA, of course, every 3 months, and with conventional imaging every 6 months, and PSMA PET imaging at 3 months post-adjuvant treatment. So after 3 months, here they perform the PET PSMA and to look for distant metastasis. Okay, another one is the AASUR interim results. Now, this is a single arm, a phase 2 trial, a combination of two new hormonal treatment, apalutamide and abiraterone, plus here we gave the leprolide or LHRH analog, plus stereotactic ultra hypofractionation radiation. As already mentioned, the ultra hypofractionated radiation will be given 6 gray per day. So you will even shorter the radiotherapy time. But of course, the candidate will be the very high risk, node negative prostate cancers. And they already have this is the protocols. Okay, very high risk, and the patient will receive LHRH injection for every 3 months, and then continue for after 3 months. The patient will receive the stereotactic ultra hypofractionation, and the treatment arm consists of apalutamide plus abiraterone. So this is the combination of two new hormonal agents. Then follow-up will be 36 months. Then we can see here. Okay, this is the interim results of this study. You can see that after 2 years, biochemical recurrent-free survival is quite high, it's 95%. And after 2 years, slightly decreased to around 90%. It is quite high. You can see here, this is a Kaplan-Meier graph of these cases. So after 2 years, you still have 95%. And after 3 years here, it will be around 90%. The interesting findings is the median time to nadir PSA is very short, only 2 months, ranging from 1 to 9 months. And as already mentioned, that almost 99% of the patient achieve an undetectable nadir PSA. I think reaching a nadir PSA is very important in terms of looking for the future of these patients. So it is like marker. If they can reach the lowest nadir PSA in the shorter time, it means that the tumor itself will be well controlled in the future. So median time, the post-treatment non-castrate testosterone is 6.5 months. Okay, now how about the safety profile? Here we can see that hypertension is the most adverse event, around 18%. Of course, it will be still manageable, and rash is less than 5%. So in conclusion from this study, that the treatment regime shows a strong efficacy and favorable safety, as you can see here. And so I think this will be an interesting choice in the future. So another study. This is again, we will have an interim results from the starter study. Again, this is phase 2, the salvage trial, androgen receptor inhibition with ADT plus apalutamide and radiation therapy, followed by docetaxel. So this is a kind of triplet therapy, but not in one time. So you give apalutamide upfront and then you follow with docetaxel in PSA recurrent prostate cancer after radical prostatectomies. So again, this is important for us who nowadays, I believe in Indonesia, we do more and more radical prostatectomies. So you have to do a close follow-up to your patients. Okay, this is the inclusion criteria. PSA relapse within 4 years after radical prostatectomies, high Gleason score or Gleason score 7 with high-risk features, PT3 or N plus or a positive margin, and of course, at least up to 4 pathological positive lymph nodes. And the detectable rising PSA should be more than 0.2 nanogram per ml. So you can see the protocol here. Biochemical recurrence, the number is not is still small, 39 cases, and they gave apalutamide plus ADT for 36 weeks, and after that, starting in the meantime, you start the radiation therapy, the sulfates radiotherapy, and then after stopping the apalutamide, followed by docetaxel for 6 cycles. Again, I think this is another modality that might be in use for clinical practice in the near future. Okay, here is the results. At 14 months median follow-up, they don't see any PSA progression event. So everybody will have a low PSA. So the response is it's very, very high. And around 40% of patients experience testosterone recovery. And this is also important in terms of the quality of life, because we know that with low testosterone levels, the patient will have an additional problem, such as metabolic problems, hyperglycemia or hyperlipidemia, or just the simple situation with patient with low testosterone, like they have a tendency of fatigue and increase of body weight and so forth. And out in 14 months follow-up, no patient have died. So this is an interesting finding. And if you look at the common toxicities, hot flush, fatigue, okay, there are some fatigue, dyschezia, rash, and alopecia. Of course, with the additional docetaxel, we can have leukopenia and neutropenia here. So the important finding is that this multi-modality treatment with apalutamide plus ADT, sulfates radiotherapy, and 6 cycles of docetaxel is a promising efficacy in well-tolerated patients with this PSA recurrent. But once again, this maybe could be applied to patients with several high-risk factors. And this is another study. This is the ongoing phase 3 open-label randomized multicenter study evaluating enzalutamide plus LHRH plus EBRT, once again in patients with high-risk localized prostate cancer. In earlier, I already mentioned about the similar study using abiraterone. This time they use ENSA, and they have 800 cases, dividing into 2 groups: ENSA plus LH plus EBRT, and the other group received a conventional non-steroidal anti-androgen plus LHRH and EBRT. And this is the inclusion criteria for the study. Again, this is for the quite high-risk patients, listens 8 to 10. However, they still include a clinical T2B, and this should be more than 20 nanogram per ml or an N1 disease. Okay, this is the other patients should have HB more than 10, and of course the other good kidney functions, good liver function, and so on. Okay, I will follow with this last study that I will present. This is the RNEO study. This is a randomized phase 2 trial. Again, neoadjuvant degarelix. This is an LHRH antagonist, with or without apalutamide prior, once again, prior to radical prostatectomy. So again, this is a neoadjuvant setting. What is the background? If you look at the patient population, the incidence of high-risk prostate cancer is actually around 20%. But if you look at the patients who have been treated, and we have a look at the 5 years prostate cancer specific mortality, most of them are a patient with a high-risk prostate cancer. Similar we see in 10 years cancer-specific mortality. So it can conclude that if you have a patient with high risk and you did operation or radical prostatectomy, you will expect after 5 or 10 years, most of these patients will dominate the number of cancer-specific mortality. Therefore, they start to have this study with this protocol. They use staging with the PSMA, PET, or MRI. Then they start to give the degarelix or LH antagonist plus apalutamide, and the other group receiving degarelix and placebo. But after 3 months, they did another PSMA PET to evaluate about is there any effect in terms of imaging to the patient, and then after that, then they did the surgery. Okay, this is an interesting finding that they look with the imaging, you can see a residual cancer burden lower in the patient who received the treatment. I mean, degarelix plus apalutamide. So minimal residual disease in patient who received this treatment compared to patient receiving placebo. And look at the specimen after operation. This is also interesting. For the patient who received placebo plus degarelix, you see that the pathological report is almost for the PT1, T1, T2 is almost the same, PT2. But again, here, more and more PT3 and 4. So slightly upstaging of the cases. But if the patient receive degarelix plus apalutamide for 3 months prior to radical prostatectomy, then the chance that the pathological report will be like this. More patient with the PT2 and less patient with this PT3, despite that before therapy, actually, this is the percentage. So we can say that there are down staging to organ confined disease. So from PT3 and 4, we will go down to PT2. And of course, in common sense, we can say that if you have a PT2 patient, of course, hopefully the patient will have a longer overall survival or metastatic free survival. And I think this is an example of the imaging studies that they did before the surgery, treatment like this. This is from the PET PSMA. You can see a very high SUV in the prostatic area. And if they have an excellent response, they will have a low SUV in the prostatic area. Okay, this is after the treatment. So PSMA after 3 months. And if the patient have a poor response, you can see that almost similar or even a higher SUV on the prostatic bed in the poor response group of patients. Now, another interesting part of this study is they try to look at biomarkers, and they choose P10, and they conclude that if the P10 biomarkers lost in the baseline prostate biopsy specimen, sorry, then this patient will significantly have a less minimal residual disease compared to patient with a positive P10 on the prostate biopsy. Of course, if you have a less minimal residual disease, and of course you will have a higher residual cancer burden. Okay, so the percentage of achieving minimal residual disease less, and of course at the same time you will have a higher residual disease burden. So in conclusion from this study, this is an interesting study. I hope that they can continue the phase 3 trial, that a patient treated pre-operatively with this LHRH antagonist plus apalutamide will have a significantly better tumor response in terms of downstaging. And again, with using of PET PSMA before and after treatment, we already predict about the pathological response. Maybe it might change our treatment modality. And again, using the P10, P10 loss is a negative predictor. So if we use both of this modality, PSMA PET after treatment and P10 examination on the biopsy specimens, then maybe we can already predict which patient that will have best results in this setting of giving a prior treatment with Tegarelix plus apalutamide. I believe this is my last slide, and thank you very much for your kind attention. I will give it back to Dr. Wayan Widiana. Thank you very much. I will stop share.
Okay, thank you very much, Prof. Umas, for the interesting lecture and open our mind about the localized or locally advanced prostate cancer, especially for patients in high risk or very high risk. Previously, we know patients with localized or locally advanced prostate cancer only treatment with radical prostatectomy or radiation therapy. But now, for patients with very high risk, to optimize patient survival and to delay the progression disease, must be combination treatment with novel hormonal treatment or systemic treatment. Okay, after the finish all of the lecture, we open the Q&A from the audience. If maybe there's a question for the speaker, please. Write in chat box. Or if there is no question, we open the discussion about the case presentation by the Dr. Lukman. I want perspective cases from the Prof. Boris maybe, and Prof. Umbas and Dr. Aron Tigor about the cases presented by the Dr. Lukman. How about the if we find the patient with lost follow-up and come back with the high PSA level, and then maybe what the for the herbal treatment maybe, and delay respond with abiraterone treatment. Maybe Prof. Boris first, opinion.
Certainly. So thank you. I mean, I don't have a lot of experience with herbal treatment because it's not that popular in Germany. But I certainly do know patients that when they are asymptomatic and the PSA drop down, that they want to quit everything and they are lost to follow-up, and then they come back again with hormone-sensitive disease. So I thought that in the case, the offer of triple therapy was absolutely right, because he was symptomatic. He had symptomatic bone disease. He had local obstruction with the prostate. So I think that was a good step. He is at high risk because the PSA did not nadir nicely. Then the other urologist who offered apalutamide, I mean, this is off-label because at this time that patient, I mean, he was in partial remission with the imaging. He was asymptomatic, but the PSA was rising. So you can discuss that he's on the brink of being castration resistant, and then apalutamide is not reimbursed in our sector. But enzalutamide would be an option in this case. And then local radiotherapy, man, given his Gleason 10 disease in the prostate with status post TURP for local obstruction, this is something you can consider. In my practice, I would not have done apalutamide. He is a patient progressing after one line of hormones and after one line of chemotherapy. So I would have done a PSMA PET and then offered him radioligand therapy, or alternatively cabazitaxel. But I mean, who is treating, who knows the patient is always right. So this patient, I mean, actually he's doing fine right now. And I think there's a big debate on subsequent therapy. I have presented at ASCO GU a Spartan post-hoc analysis where we tried to find out in men who progressed early on with apalutamide, whether these high-risk early progressors should be switched to chemotherapy or given ABI or ENSA or whatever. And chemotherapy was not a clear winner. All patients progressing after abiraterone were doing okay with any of the drugs. So in academia, we always recommend a switch of the mechanism of action, but I think the data for this is not rock solid. And we are now looking at patients from the Titan study, so first-line apalutamide, and whether we can find out in subsequent treatment whether there are clear recommendations or not. So I think every patient is a journey and is exciting. And yeah, as I said, I would not have given APA because we would not have reimbursement for that in Germany.
Thank you, Prof. Boris. Maybe Prof. Umbas or Dr. Aaron Tingor.
Okay, thank you very much, Dr. Yudiana. Thank you, Dr. Lukman, for sharing your interesting case. I think you already remind us that in this kind of a patient that he comes first to another urologist, and he came to you. And then after several months, again, stopped his treatment by himself and came back again. I just to remind that in this situation like this, it's always wise to do a complete restaging evaluations. Means besides you check his PSA, check his testosterone, and of course, if it is possible, repeat the like you already done, repeat the MRI. What is the situation at this moment when he, I believe, when he come back again with the PSA of 600 or something like that. And it is quite good, the decision. But I think it is always also wise if you start to do germline or somatic testing in this stage, because maybe we would have in our mind that this patient might be progress again in the near future. So why we don't take the if it is possible, of course. That's my if I have the chance or the patient can pay, as already Prof. Boris mentioned, it is not yet reimbursed even in Germany, that maybe if they would like to do this, I would advise them to do a germline or somatic test. Thank you.
Abi, Dr. Aaron Tigor.
Well, I think this is this. It is. I'm looking at that this patient already have a treatment in 2017, right? And waiting for that time until 3 years, it seems that the patient is okay. So I'm thinking about is this patient have a different kind of cancer? Although in 2020 that we have a specimen probably different from the 2007. I don't know, because in 2017 the biopsy result is negative, and I believe that you do a second MRI. Is that right, Dr. Lukman?
Yeah.
And then the RECIST criteria showing, I believe it's 50%.
Partial response.
A partial response. Well, this is my. Well, I don't know. If I have a partial response, although there is an increase in PSA, I don't know. What do you think? I think I will wait till several months and see. I will still use the abiraterone and see whether or not it will be working. And I agree with Professor Umbas that we should have a genetic testing for this patient. But looking at the RECIST criteria, I will wait for a while and see the response of the apparatus. That's my opinion. Thank you.
Yeah, can I give a short comment, Dr. Ridel? Yeah, I fully agree with all of you that it's quite difficult to convince our patients, particularly if they still believe in herbal medicine. Some of them probably also believe in magic. Somebody else, sending magic things to them so that they suffer from severe disease and so forth. But I did my best, and I fully agree that apalutamide is actually off-label at this moment. It should not be given as a follow-up treatment. And then, Dr. Aaron, I intended to extend the ADT plus abiraterone, considering the possibility of PSA flare. Actually, that was the plan. And if it doesn't work, then we will discuss again for other treatments of MCRPC as a progression. And it is correct, Prof. Umbas, I did the germline and was it also somatic testing? No, the ctDNA that we had in one lab in India. This patient was also included, and the results was negative for him. So I do believe that if we consider this patient in the future as having progression to MCRPC, this patient would not be a good candidate for PARP inhibitor at this point. I think that's to clarify on the issue. But thank you very much. It's a very nice discussion.
Thank you, Dr. Lukman. Maybe, is there any question again? Okay, if not yet, I want to ask for the Prof. Boris. In one of your slides, the treatment pattern in US still most ADT alone for patients with MHSPC, and in Indonesia is same like that. Can you explain why the most of patients still offer the ADT alone? Because we know the many research offer the recommendation the double and triplet therapy for MHSPC. Thank you.
So, I mean, the data I showed that was presented at ESMO last year is from 2022. Now at ASCO, Raj Agarwal showed in an educational session updated results looking at now 2022 or a little bit later, and he could show that the doublet therapy is picking up like 40% or so. It is coming. I think it really depends on the healthcare context. In the US, and these were VA patients, I think financial toxicity is really an important consideration. And I know that in Germany, there are still many urologists who want to find out how is the PSA response when they start with ADT monotherapy. And so they are starting with ADT and then waiting for the PSA to come down with the belief that it might be good enough to intensify treatment if the PSA is not dropping below any defined value of them. And so I don't know how these individual starters like ADT and then intensification a little bit later are captured in the real world evidence databases, because I mean they don't question every few weeks, they just question how was, or look at the databases, how was the therapy started. I personally do not use ADT alone anymore, and I don't use bicalutamide, for example, anymore. I do start my patients at once with a doublet if they have de novo metastases. It is hard for me to really comment, but I think there are many urologists that start with ADT mono and then want to see what happens. But in the clinical studies, this was not the case. So the evidence that we have that clearly shows that doublet therapy is prolonging overall survival, so an important endpoint, this was like start from the beginning. So I personally believe that if you hit early, you should hit hard. And then we can discuss, if you have very good responders, to de-intensify later on. If the patient or the family reports to me, the husband is a lot of fatigue or he is not doing well, but the PSA has dropped down nicely, then I'm absolutely open to de-intensify and discuss whether we make a treatment holiday and de-intensify treatment. But in the beginning, I really recommend to hit hard.
Can I have some question, Dr. Yudiana?
Yes.
Yeah, I'd like to address the question to Professor. Is ADT plus docetaxel as a doublet therapy still an option for MCSPC in Germany? Because in Indonesia, all the doublet therapies options for MCSPC, only ADT plus chemotherapy is completely covered by the national health insurance. None of the novel hormonal agents are covered. How is it in Germany?
Yeah, in Germany, the novel hormonal agents are covered, with the only exception, abiraterone is only covered for high risk because of the latitude study. So you have to pay attention there a little bit. But everything is covered. On the other hand, there are some certification processes, and some urologists are looking forward to giving chemo because they have to apply a minimum amount of chemotherapy to keep this as a reimbursed option in their practice. I think the updated EAU guidelines are very clear. Docetaxel alone should not be given anymore because it is inferior to a triplet. So we don't use it in my academic praxis anymore as a doublet therapy, only in part of triplet therapy. But as you said, in real world practice, I do know colleagues who still recommend ADT plus docetaxel. But from a patient perspective, it is not my first choice because this quality of life decreases a little bit. I mean, it's not a dramatic dip, but it is a decrease in quality of life over 3 to 6 months. That is a pity. But if local reimbursement, I mean, ADT plus docetaxel is clearly superior to ADT alone. So it's really a local discussion, and all my patients will get chemotherapy at some point in time. So you have to discuss with the patient, and if he wants to start with chemo, then why not?
Okay, thank you, Prof.
Maybe Dr. Aaron or Prof. Umas have experience with triplet therapy. I'm sorry, Prof. Still mute.
I'm so sorry that me myself, I don't have any experience with this triplet therapy. I mean, docetaxel plus ABI.
Yeah. Can I have one more question, Dr. Yudiana, if there are no
Yes.
other questions? Yeah. Again to Professor Boris. If you perform the triplet therapy, what is the suitable schedule between ADT, chemotherapy, and abiraterone? Do you concomitantly provide all the three together, or you provide a short distance between the three agents?
So the patient you presented with starting docetaxel, then seeing how he's doing. Then
After 2 cycles.
And then add in abiraterone, I think that's perfectly reasonable. For us in Germany, we would now favor the combination with darolutamide and docetaxel, which is already reimbursed with us. So I would start with ADT plus darolutamide, and then I schedule him into our chemo clinics with a waiting time of approximately 3 weeks. So we know ADT plus darolutamide, and then we start docetaxel. But this is like our local setup.
So I believe there are no exact schedule between the three. And if we take a look into the triplet therapy clinical research, the RCTs, the phase 3 trials, all of them provided the three differently, but all of them have similarities. The three agents given within the first 3 months' time. Am I correct, Prof?
Yes, I think so. I mean, the ENSAMED study, they had a little bit different setup with the docetaxel before. So in Germany, we will have another study where we compare docetaxel 3 weekly to 2 weekly in combination with darolutamide, because the docetaxel 2 weekly regimen might be a little bit beneficial from a quality of life perspective. But this is not a big non-inferiority trial. It's just a Me Too study.
I think it would be wise not to provide all of them simultaneously at the same time, considering the efficacy. Thank you, Professor Boris.
Maybe I will ask some question to Prof. Boris, like you already mentioned that at some point, maybe some of our patient needs the PSMA treatment. And do you have any, let's say, cut-off point based on the PET PSMA findings to choose which one is suitable for this lutetium treatment? Thank you.
So there was a time when we did like the Australian friends PSMA and FDG PET and looked whether there is mismatch or not. Now we looked at this data set and compared it to vision criteria, which are a little bit easier. And we found out that the FDG PET is not that useful. So it is an expensive exam that you can leave away. So we just do a PSMA PET CT, and then you have, depending on the tracer, you have to compare the intensity in the tumor to normal organs. So for example, in vision, the PSMA PET signal in the cancer should be above the liver. Yeah. And then they're good candidates. I mean, the higher the PSMA positivity, the higher the likelihood of response. So the easiest is if you compare the parotid gland intensity to the cancer. And if that is similar, he's a good candidate. And there should not be any metastases without any signal in the PSMA PET. Yeah. So for example, if you see big lymph nodes without signal and only a few bone metastases with signal, there's
Not
mismatch.
good.
This is not a perfect candidate.
Okay.
If you use the PSMA 1007 tracer, their excretion is through the liver. So the signal in the liver is much higher than PSMA 11. There you have to compare to the spleen. So it's a discussion with nuclear medicine, but at present we favor the vision criteria. So just comparing cancer should be above the liver, yeah, and no lesions without any signal intensity. In general, as a rule of thumb, in our practice, 7 out of 10 patients we image are eligible for therapy. And we have reimbursement post chemotherapy and post at least one line of novel hormonal therapy. And so it is competing with cabazitaxel for the same patients. And at that time, we also do the BRCA testing. So if we find a patient, but this is 1 in 20 in my practice, with a BRCA2 mutation, clearly this patient gets a PARP inhibitor and then later on lutetium PSMA. I mean, there was now a LuPARP presentation, so combining PARP inhibitors with lutetium. This looks very interesting, but it's not standard practice. And at ESMO, as a small teaser, I hope to see data of the combination of lutetium PSMA plus enzalutamide. So it's called ENZA-P, because we know that with enzalutamide, the PSMA expression goes up a little bit. So this might be an interesting combination at some point in time.
Thank you.
Okay, thank you, Dr. Boris. Okay, because the time, if there is no any question, I try the summary in this topic. First, based on tumor burden and tumor heterogeneity, especially in patients with metastatic disease, do not offer ADT alone or ADT monotherapy if there is no contra indication for combination therapy, sufficiency life expectancy, and willing the accept of adverse event. Double combination systemic treatment is the most choice for the now, with emphasis add to the novel hormonal treatment then chemotherapy. Triplet systemic treatment will be challenging, mainly to patient selection, such as do de novo high volume metastatic hormone sensitive prostate cancer. And then for patients with localized disease or locally advanced with high risk or very high risk stratification patient, not only enough treatment with radiation therapy or radical prostatectomy, combination with prolonged ADT or maybe in the current guideline, combination with novel hormonal treatment can be optimized, prolong the overall survival and progression-free survival. In the future, test for the genetic testing and another biomarker for the precision medicine and individualized medicine can be option for the patient with cancer. Okay, thank you very much, Prof. Boris Hadasik, Prof. Umbas, Dr. Aaron Tigor, and Dr. Lukman Hakim for the interesting lecture in this event, Prostate Cancer Scientific Discussion 2023. I hope all of the speaker good, healthy, and the time back to the Dr. Linggar. Thank you very much, and good afternoon for the all.
Thank you. Thank you,
participants.
everybody.
Thank you very much.
Thank you very much.
Thank you very much
Thank you,
for
everyone.
Dr. Iwayan Yudiana for moderated our session. Sincere gratitude also from us to Dr. Aaron Tigor Siombing, Special Urology, Professor Dr. Boris Hadasik. Thank you so much for your time for us. And Dr. Lukman Hakim, Specialist Urology, and Professor Dr. Raini Uba, Specialist Urology Consultant, for sharing and emphasizing the role of novel hormonal therapy in MHSPC patient. So before we close this session, we would like to say thank you for all attendees and for attending until the end of the session. Please kindly fill our post-test and feedback survey through the link on your Zoom link or capture the barcode on your screen. So next, we would like to take a documentation photo for this awesome session for all attendees and speakers, of course. Please open your camera to take our beautiful end session. Mbak Nia, could you help us to take a documentation, please? Photo?
Yes, Mbak. Could you please stop share for a moment? Okay. Get ready. Okay, 1, 2, 3. Once again. 1, 2, 3. Last one. Okay. 1, 2, 3. Okay, thank you.
Thank you so much for all speakers. Thank you so
Okay,
much,
thank
Jansen
you.
and PPYOE
Bye.
team for this session.
Thank you, everyone.
Thank you.
Bye.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you.
Thank you so
Thank
much.
you, Prof.
Yes,
Umbas,
Cindy,
Prof.
Yes,
Boris,
terima
Dr.
kasih.
Aaron, Dr. Lukman.
Terima kasih.
Thank you. Terima
Thank
kasih.
you, Dr. Linggar, Dr. Arlin, Dr. Dian.
Terima kasih udah mau sehat selalu.
Terima kasih semuanya ya. Saya lihat dulu. Oke.
Oke, izin live ya, Dr. Linggar,
Terima
Dr.
kasih dong.
Arlin, ya,
Dokter,
makasih,
sehat
ya,
selalu.
sama-sama.
Oke.
Sehat selalu.
Dr. Aaron, Dr. Dian, izin live. Terima kasih.